Okay. Oh, they're going to. No.
Okay, good morning, everyone. Let's call this meeting to order at 9:05. We're calling the JLMBC April meeting to order, 9:05. Can we go ahead and do the roll call?
Thank you very much. Okay, we are going to start roll call with management and then with the employee organizations next. Malika Billups. Tony Royster.
Here.
Matthew Rudnick. Matthew Sabo.
President. Culturati.
I'm sorry.
Matthew Zabo, present.
Thank you, Paul.
Sure.
Patrice Latimore.
Here.
Janita Igualer.
Here.
Marlene Fonseca.
Here.
Chad Boggio. Esteban Lizardo. And Lisa Palombi.
Here.
We have quorum.
Okay, awesome. Great. Okay, are there any public comments?
At this time, we will take public comments. If you are participating via phone, please press 9 and announce yourself. If you are in the room, please drop off your speaker card. There are no public speakers for today.
Okay, great. Then we can move on to the next. Oh, you know what? Do we need to approve the minutes from last time?
The minutes are not ready for submission to the JLMBC today, unfortunately.
Okay, all right, then we can go ahead and move on to informational items. Committee report 2010, an update of the 2027 LA Well Plan renewal.
Okay, I will be presenting this report, and staff from Keenan will be going over some of the items in the presentation deck shortly. So for this report, staff is requesting that the JLMBC receive and note the update for the 2027 LA Well plan benefits and costs. The included attachment from Keenan's contains an overview of the negotiation results with the current LA Well program benefit providers. Staff is also reviewing program rules and potential changes that should be recommended for plan year 2027 implementation. We anticipate having the full package ready for JLMBC at the May meeting.
Good morning, and thank you for your time today, honorable members of the JLMBC. My name is Megan Gardner. I'm here with Keenan, and I'm joined by Ford and Gar. Also of Keenan, we do have Terry Graff and Jillian Turner with underwriting on virtually today. We want to provide just a brief overview of the initial benefits look for the 2027 LA Well program. We're going to go through what we're seeing so far, a little bit of market trend to kind of level set, and kind of some next steps for the program. Do you want to jump down a couple of slides here? We've provided a bit of an executive summary that kind of gives you a snapshot of where everything's landing. As of today, medical renewals are somewhat pending. We did get in renewal positions just last night from Blue Shield and UHC. They have not yet been reviewed by underwriting, and we are still pending a renewal position from Kaiser. It's a little premature to chat about what it's looking like, but we did want to talk about the trend to give you some context. We also do have and have received in dental and vision rate positioning. Dental is coming in at a 3% proposed increase. That is at the negotiated rate cap from the previous RFP. There is no change on the DHMO. That is still in rate guarantee. So sitting relatively flat on the dental front, but we are reviewing the dental proposal for leverage and negotiations. And we're also evaluating the self-funded options. And I know we're going to be talking about self-funding a little bit later in today's meeting, but that is something that we are actively working on as part of the renewal package for 2027. For vision, also no change in a rate guarantee as well, but we do have those self-funded options that we're going to take a look at and evaluate. Life and disability are also in rate guarantees, which is it's great. Rate guarantees across the board for the most part. So they are not changing either. And then when it comes to the Employee Family Assistance Program, that is actually being evaluated for RFP and possible contract extension. And so we have some information requests out to the carrier that we're going to be taking a look at what we get back. And then the tax advantage savings accounts, which is your flexible spending accounts, are also in a rate guarantee. So that is an overall snapshot of everything in a nutshell. If we go to the next slide, we wanted to give you an idea of what industry trend looks like across the board. This is to kind of help level set expectations on the medical, dental, and vision side. Medical trend outside of Kaiser, what we're seeing generally is 8 to 9% range. For Kaiser, we're seeing 5.5 to 7.5%, and then for prescription drugs, slightly higher at 9 to 10%. There is still a lot of market pressure and volatility in the medical space, and especially with regards to prescription drugs, which you'll hear a little bit about today from Blue Shield and UHC as well. And we heard from Kaiser previously. With respect to dental, it is a banner year. We're seeing a little higher renewals on the dental front than we've seen in years past at 4 to 5%. And then with vision, generally around 2 to 3.5%. Gordon, do you want to chime in at all on industry trend?
Yeah, those are the insured industry trends in a self-funded environment, which I'll talk to later. The trends vary a little bit lower is what our experience has been.
Yeah, we're going to chat about that for sure. Next slide. So as mentioned, Blue Shield and UHC hot off the presses last night. We got their renewal packages in. They have not been yet evaluated. And at the time of the report, that was kind of where we're at. And we are still pending a renewal package from Kaiser. So once we have all that in, we'll be able to really dive into the positioning of the carriers and kind of leverage and negotiate certain aspects of their renewal positions. I wanted to note that both Blue Shield and UHC have rate caps in place for this. Well, this will be their second year of their contract. Kaiser does not have a rate cap. They usually charge for that and kind of bump up and load rates. And we decided not to go that route this last year in the RFP. So they do not have a rate cap on the table. So we will see what we get when their renewal package comes in. I also wanted to note that for both Blue Shield and UHC, they are working off of immature claims experience. So we are all of 3 months into their plan year. That is not a long runway with their own experience. So we are kind of keeping an eye on that. We did provide them with experience from Anthem prior to see how the plan was running. However, that is the entire population and not necessarily ticked and tied to their actual subset of population for them to evaluate. So they're using that for kind of an illustrative look in context as they went through their renewal process, but it is not an exact. So we anticipate this is going to be a somewhat conservative look at medical renewals this year based on those factors. Anything to add, Gordon, there?
Yeah, anytime you move to a new carrier, it's just a very difficult transition in underwriting the subsequent year. So we'll do our best to make sure that the carriers understand the goals and objectives of the city, as well as making sure that the assumptions relative to the rates that are presented are not too conservative to the point of too great a burden on the city and on the employees.
We'll move on to dental unless there's any questions. Again, dental, we did get an initial renewal package from Delta Dental. They came in at a 3%, calling for a 3% increase. That is the rate cap that was secured through the last RFP. And it is a rate guarantee rate pass for the Delta DHMO. The DHMO actually had a 5-year rate guarantee that was secured through the RFP before, so that is very good. We are keeping those performance guarantees in effect. We are reviewing the Delta renewal for appropriateness and applicability. And also looking at the self-funded options and proposal that was also secured through the RFP to see if that makes sense. And Borden's going to touch on that a little bit here today, later on. Next slide. I'm going to talk and dive into vision. Vision's also in a rate guarantee, which was secured through the RFP. This year vision program is the Anthem Blue View Vision that is on the iMed network chassis. They have actually this year proposed a $10,000 wellness fund included for 2027 in the spirit of partnership. So we are taking that into account. There are no mandated benefit changes for this program. And then we do actually have an optional rate guarantee for additional contract years. So that is very good. And then we're also taking a look at the self-funded piece. So overall, vision looking pretty good. Next slide. Life and AD&D is with MetLife. Their contract is good through 2027. They do have a rate guarantee on the table for 5 years, an initial 3 years plus optional years 4 and 5 through 2029. We did have some significant benefit enhancements that were achieved during last RFP. And so we're going to continue to monitor and evaluate plan experience relative to that and the rate position. But overall, rate guarantee, no changes. Next slide. Disability, not a lot here either. No change for 2027. We have a 3-year rate guarantee in place through 2028. Again, monitoring just experience and to make sure it's appropriate and to provide any alert should there be any spikes that we need to make you all aware of. Next slide. Employee Family Assistance Program. So this is one that we did put out a request for renewal. It is due back to us on April 9th. We are looking at that contract in totality. Right now, your initial period is expiring in the initial 3 years, and then we've got optional program years to consider. We also have an RFP potentially out there for consideration. One of the things that we wanted to look at from a strategic perspective for the program and for EBD to manage things is a potential to move it to a fiscal year cadence versus a plan year cadence. It's not an enrolled benefit, so lining it up to your fiscal year will give you some stability with respect to budgeting and will also help to stagger procurement burdens on the staff as well. So it might make sense. So we're going to take a look at that and evaluate what that looks like and bring that back to you all to consider as part of the options. And then also looking at an RFP to look at a match to current, see what kind of rate concessions we can secure, and also some program plan design alternatives, such as virtual care, virtual options, and potentially self-funding. So lots going on with the EFAP program over the next month or so. Next slide. Tax Advantage Savings Fund. Again, this is your flexible spending accounts. No change. You're in your initial period of contract. You have a rate guarantee in place, and then you've got some contract extension periods to avail yourself of. Next slide. So this is really what our timeline looks like for our next steps. We are going to be very busy here over the next month or two, reviewing the renewal positions and making sure everything's appropriate, negotiating where we can to make sure the city's getting the best value and the best price point for your membership. So over the course of between today and into next JLMBC, we're going to be asking carriers to sharpen their pencils and putting together a look at the program options. Should there be any further renewal negotiations that are needed, and I anticipate there could be, we will work on that after next JLMBC with an aim towards bringing a final program adoption in the June JLMBC timeframe. So that's kind of our timeline, taking direction from the staff on meeting those deadlines and milestones for sure. So next slide. So at this point, our charge is to continue to roll up our sleeves and negotiate and bring back an update at the next JLMBC on a variety of fronts, specifically the medical renewals and finalizing negotiations and positioning for dental vision, and then also that EFAP program. And I think that is it for me. If there's any questions, we're happy to address those now.
Any questions?
Great. Well, thank you very much for your time.
Okay. We can move on to the next informational item, a presentation from Blue Shield regarding enrollment activity.
We have Larry. Yeah. You're welcome.
Good morning.
Good morning. Thank you for having us. Thank you. Okay, we can go ahead and get started.
Yeah.
Okay, I'm Jessica Pond. I'm the account executive for Blue Shield of California. I oversee your account with Blue Shield. And with me today, I have Michelle Donaldson, who works on the account management team with me, and Roger Tao, who is our pharmacist. Next slide. So we're going to be doing a quick overview today. For Blue Shield, you have our Trio HMO plan, which is a subset of our full network. You also have a PPO plan, which is a traditional plan, and a high deductible health plan that can be paired with a health savings account. We ended up with 21.3% of the overall enrollment, so that's 5,500 employees. And then today we're going to do an overview of the member transition experience, member engagement. We'll look at some preliminary pharmacy and medical data as well. Next slide. You can probably forward to more. Yes, right here. Thank you. So the member transition experience. From there.
So we wanted to highlight where the members fell during the open enrollment and provider file that we had. So we had 5,715 members that we incorporated onto the open enrollment file. 3,686 were assigned a PCP that they had selected. Close to 1,300 were auto-assigned because there were no primary care physician on file. And then 741 were also auto-assigned. There was no address in our Trio zip code for the selected provider that they had on file. We had 4,023 members on the PPO. And then for the high deductible health plan, we had 262 members. The continuity of care cases that have come in from open enrollment through to February for all the HMO and PPO plans were a total of 22 cases. 3 were acute, 2 were chronic, 1 pregnancy, and 14 were behavioral health. Next slide. We wanted to show you where the call volume was coming in through the member advocates. We have the calls, and then we also have the Calendly. Those are the one-on-one telephone calls where members can go and schedule a time and a date that works for them. So over the past 4 months, we have taken in 3,881 calls and 63 meetings. The breakdown in the pie chart below gives you an overview of where those calls and topics fall into. 40% being provider related, 15% related to eligibility, 11% for admin, 7% for general questions, 12% benefits, 8% supplies, 4% utilization management, and then 3% fall under prescription, enrollment, billing, and appeals and grievances. On the right side of the slide, we wanted to highlight a couple comments that we have received from members. They have the option after the telephone calls to complete a survey, and that's basically leaving a comment, or they have outreached or spoken on the phone to the member, just giving them the praise that you can see here. Next slide. We did put together a dedicated microsite for the City of LA employees. There are several links embedded in the microsite, and the different screens that you'll see on here is actually as you scroll through the microsite. There's a link where it shows them how to access the Blue Shield website on their telephone. They can make their PCP changes right on via the computer. There's a pharmacy price checker. They can schedule that meeting that I mentioned with a member advocate, which is the Calendly. You can find a provider there, and we do have the specific links for the various plans. So if they're an HMO member, a PPO member, it goes straight to that network of doctors. It makes it a lot easier for them to navigate. They can view their benefits. They can see their summary of benefits. Their EOC will be posted. They can also see a lot of the extra type plans that we have or discounts available, such as our away from home care plan. They can look into well-being, our Wellvolution program. Again, there's just lots of different information. And then the direct link is there, and it's blueshieldca.com, LA City. Next slide.
So I'm going to go over the member engagement and support slide. So there's many ways that we engage with your members so we can help them navigate the Blue Shield system. You know, obviously we're here as a new carrier, and so it's a little bit different than what they've been used to. So the main or the first point of contact is Shield Concierge. So this is our customer service line, but it's also staffed with care managers as well. So depending on what the person is calling in for, they could end up talking to a registered nurse or a social worker or a dietitian or a pharmacist, depending on what they need. So far, we've got 105 people who've enrolled in one of these programs with Blue Shield. Care management can really span many different types of issues. From if you're in the hospital, there can be discharge planning to make sure that you have, you know, your home set up so you can continue to care for yourself, or if you need caregivers. But we also want to really focus in on those people that have chronic conditions to help them manage their care, whether they're pre-diabetic or diabetic, if they need physical therapy or they have cardiovascular conditions like high blood pressure. We've got programs within our care management, but also in our wellness platform. Michelle mentioned on our microsite, you really can get to all of these tools. And so Wellvolution, it's our digital healthcare platform. And so what it is it's actually a combination of several different apps. So it's self-guided and it's based upon a questionnaire that you would answer and what your health goals are. So currently, you have 28 people enrolled, and you can see that some of the programs that you're probably familiar with are Weight Watchers and maybe Headspace. That's for stress management and mental health care. SWORD is a digital physical therapy platform that your members can enroll in and do it digitally. And some of these programs you have to qualify for. So if you're just wanting to lose weight, you wouldn't necessarily qualify for our diabetes program or our diabetes prevention program. You might be paired up with something like Weight Watchers. So it's more nutrition focused and exercise focused. But these programs are available at no cost to your members. So they're able to use these with no out-of-pocket. Teladoc is another resource that we have available. Some of you probably have heard about it. It's basically mostly used on the medical side for acute issues. So instead of going to an urgent care, maybe it's the middle of the night and you've got a sick child and you want to call in and speak to a doctor about the issue. They are staffed with doctors so they can prescribe medication. Usually it's like an antibiotic type situation. You've got 60 people who have used Teladoc so far. And just to call out as well, we have Teladoc Behavioral Health also. So if somebody wants to call in and speak with a social worker or a psychologist, that's available to them as well. These plans for Teladoc are no cost to the members. For those people on the high deductible health plan, they are subject to the deductible, and then it would go into the coinsurance. But for HMO, traditional HMO and traditional PPO, it's no cost to use Teladoc. And then Nurse Help 24/7, same scenario. It might just be if you want some advice, you want to talk to a nurse, that's also free. It's 24 hours a day. You've had 20 people call into Nurse Help. It's different than Teladoc in that they can't prescribe medication. So overall, 3,133 people have called into Shield Concierge and gotten some help with their issue, whether it be, just understanding their benefits, finding a provider, or getting some help navigating into a program that might be beneficial for that member.
So for the Well Evolution, you said some of it you have to be eligible for. Does that mean you have to have a provider refer you or
No,
based
no.
on the self-taken quiz at the?
Yes, it is. So for example, yes, so eligible, so everybody's eligible for it, but the programs that you get matched to, so if you have diabetes, then you will get matched to Dario because that is a diabetes management, diabetes reversal program. If your BMI is not high enough and you're not pre-diabetic or diabetic, you could be paired with Weight Watchers. That kind of helps. Okay. Next slide. Going over to.
So what's shown in front of you is a table of pharmacy claims, retrospective pharmacy claims that were received from Anthem that were filled from November 2024 to 10/25. And this is kind of a retrospective projection when carriers move to a new carrier from the previous carrier to see kind of what potential disruption could happen when one formulary changes to a new formulary. So on the left-hand column here is Anthem's tier 1, 2, 3 formulary is on the left side. And then on the horizontal side is our Blue Shield formulary, which goes from tier 1 all the way to tier 4. So typically tier 1 medications are the most cost-effective generics. Tier 4 are typically the more costly specialty medications. So the color coding here is really kind of designed to show that blue is really neutral, quote unquote, disruption, meaning it's the same tier as the prior carrier. And the green shows either lower tier compared to the prior carrier / lower copay, whereas the red is a negative disruption where it's a higher tier / higher copay. So the purpose of this table is really to give you an idea of where we project the potential disruption to be moving from the Anthem drug formulary to the Blue Shield drug formulary, because all formularies are slightly different between carriers and potentially products. And this is really give you an analysis of all the claims that were paid last year with Anthem, how they would potentially look with Blue Shield if we had the entire population. So this just kind of gives you a rough idea of how it would project out into the future, which is now. And for example, here is about 100,000 claims that were under tier 1 Anthem. They're also under Blue Shield tier 1. So essentially it was $10 last year. It was also $10 this year. So that's kind of a neutral disruption. And then the negative disruption would be about 1,700 claims that were tier 1 Anthem are now considered tier 2 with Blue Shield. So that would be considered a negative disruption. So Anthem was $10 this year. If those claims were processed under Blue Shield, those would be $20 or higher tier 2. And then conversely, on the about 3,200 claims that are labeled green, those were previously tier 2 under Anthem, $20. Those would be $10 in the Blue Shield. So that would consider that a positive disruption. So, when you kind of net all this out, it's either projected to be overall neutral or slightly positive transition, at least on the formulary side. And I think that's reflective of what Michelle had shared earlier in our call volume. I think it's about 3% that really only related to RX. So the transition to Blue Shield, at least from the Anthem perspective in the formulary, has been, at least conservatively speaking, neutral, slightly positive.
Next slide.
Yes, next slide. So purpose of this slide is to give you an idea of what I think the industry is facing with regards to the very popular GLP-1 medications that we see out in the news and the media. And this is to give you orient kind of a group of where the clinical landscape at the moment is as of right now. There are 2 major manufacturers that make this medication, Novo Nordisk and Eli Lilly, and then listed there are all the brand name drugs. So Ozempic and Manjaro are for diabetes, typically, not typically, but they are indicated for diabetes. And then the weight loss versions for obesity are Wegovy and Zepbound. And then as you can see there, under the FDA approved indications, they're also used for other indications outside of obesity and diabetes. So MACE is essentially, if you've had a heart attack, if you had a stroke, it's approved for use in that indication. Also for MASH, which basically is liver cirrhosis, not due to alcohol. That's also approved for Wegovy. And then one other one is sleep apnea. So if you have the diagnosis of sleep apnea, it's also approved for use. And what we're trying to show here is as we move forward in the next 3, 6, 12, 18 months, the increased number of formulations and uses of these class of medications will only increase. So about 2 months ago, the oral version of the GLP-1s was released. It's conveniently called Wegovy. And yesterday, the FDA approved Eli Lilly's version, oral version yesterday. So within the last 2 months, the new oral formulations have just now been released out into the market. And then projected within the next 12 to 24 months, we should expect additional uses, indications for these class of medications. So taken all in its whole entirety, we really project on top of the existing very high demand, we do project increasing demand due to new formulations, new easier formulations with pill versions, and also additional new indications that the FDA approves.
And next slide.
Slide.
So as Megan talked about, the claims that we have right now are just through February, so they're very immature, not really reliable in order for us to look at projections, but I did want to share some preliminary data that we have in. We've talked a little bit about the enrollment and where it falls, so you can see for January and February, where we have the HMO members, subscribers are employees, members are total membership with dependents. The high deductible health plan with 44 employees enrolled and 262 total members on that plan. There are some emerging high cost claimants. Through February on the HMO, there are 9 over $50,000. We use $50,000 just as a benchmark when we talk about high cost claimants. So it could be fairly low for how large of a population you have, but that's kind of the threshold that we use. And then the PPO has 26 claimants over $50,000, 2 of which are on the high deductible health plan. And the conditions that are in these high cost claimants are cancer. There were a couple of people with sepsis, which is a life-threatening infection. Usually you're inpatient at the time. We have I think a liver cirrhosis, a liver disease, and multiple sclerosis in there. But we'll continue to keep, an eye on these. And again, encourage, if you hear from your members, encourage them to call Blue Shield because we really have a lot of tools that can help people manage their conditions in conjunction with their provider. And next slide. Yes, any questions?
I do have a couple. One regarding the 2 people that are on the high deductible plan. So, and maybe this is even a broader question because I know when we talked about putting that plan, making this something available, that was something that we were definitely had concerns about. So, were these folks they made aware of the risk associated with getting that plan?
Well, I mean, when we did have people during open enrollment, at your open enrollment meetings, I think some people might be familiar with a high deductible health plan. We did have people at the open enrollment meetings ask about that. It was, because it's a new plan and people don't really understand it. I mean, usually what I tell people is, if you don't use the plan a lot, that's great because you're paying a lower premium. So you're not having to pay a high premium when you're not really using the plan. But you also need to understand that if you were hospitalized or had a major medical condition, could you afford the out-of-pocket maximum, because that's the annual amount that you would pay in in the plan year. So, I mean, I'm hoping that people did their research up front, because when you look at the benefit summary, you can see that everything is subject to the deductible, and that includes prescription drugs. So if you're taking, a monthly prescription drug and it's a generic, it's probably not that big of a deal. It's inexpensive. But, for people that have a serious medical condition, I mean, it's definitely something that you really want to understand. So I don't know that people fully understand it. I hope they did. The health savings account is there, and that's a whole other type of benefit. If people can afford, say, if you wanted to be on a PPO, but the payroll deductions are too high, and you choose the health savings account, I like to offer up that if you take the difference between what you would be paying on the PPO and what you're paying for the high deductible health plan, if you can set that money aside in your health savings account, that is there for you to use as you incur expenses. It's also a tax savings vehicle. So a lot of people have it for that reason, and then it grows over time, and you pay for your services pre-tax, and your money is taken out pre-tax. I don't know if you are doing payroll deductions. I don't think so. I think it's voluntary right now for people to enroll. Yes. So that's a very long answer to your question. I don't know if I answered it.
It did kind of, because I think when we were really talking about adding this as a possibility, one of the things that was concerning for us is we wanted to make sure that there was an over-education on making sure that people really understood what it was that they were like, signing up for. And I guess my question is so, when folks were got that plan, was there like a reinforcement of, okay, so this is what this means, and I get what you're saying with that it was people's responsibility. You're saying that you were hoping that people did their own research, but I don't know if there's a way to be able to quantify this, but once people understood that the potential risk, did you guys see, or is there a way for a metric that you guys have that shows that, people elected to, let me go ahead and get into something that's a little bit more traditional? Is that a metric that you guys have?
I mean, we might be able to look at some of the calls for the people that were on the high deductible health plan.
Yeah, we can definitely go back.
Yeah,
if there's
and
a waiting
see.
list too.
Okay, it's just.
Yeah, no, it's a good thing, because sometimes people just pick it because it's the lowest cost plan, and we don't know why they're picking it. But 44 people isn't a lot of people. Usually when we introduce a plan and people don't understand it, the next year with word of mouth and other people that have been on the plan, sometimes more people enroll. I mean, it can't, I'm on a high deductible. I like it. But I usually hit my deductible every year. So
I have a general question, and maybe it's more for staff, but on these formularies, why are they different from provider to provider?
Formularies are designed to serve all carriers, design their formularies really to kind of balance two kind of key objectives. Number one here is access, and number two here is to kind of find the most cost-effective medications, relative to its cost. So if you have a very high cost medication, what is the value compared? If there's a more cost-effective, similar, cheaper medication, therefore, how do you balance the coverage on those? So those scenarios here is you choose similar medications that treat the same disease. If one's more expensive, typically, and they work kind of similarly in terms of how they work treating a condition. Typically, the lower cost medications would be put on a lower tier. The higher cost medications would typically put on a higher tier / excluded from the formulary. So the formulary tool is kind of designed to kind of balance those two factors. And with regards to how they're potentially different between carriers, that's a factor of individual carriers' kind of priorities in terms of financials and kind of the arrangements between the PBM and kind of manufacturers. So when you kind of mush that all together, if you can line, Kaiser, carrier A, B, and C, they're all slightly different because of kind of those variables.
Does it change from year to year?
Yes, it can. Yeah. As new drugs come on, or effective drugs come on, typically they change quarter to quarter because all drugs that are on the formulary have to be approved for all carriers by a committee that includes clinicians. They vote whether to include it on the formulary, and then on top of that, what tier, and all that clinical and safety and cost data is evaluated to figure out kind of where that drug should be placed.
And the information is on our website. You don't even have to be logged in to look at the formulary. And then you can also drill down and look at what's changed.
Thank you.
Can I just, an add-on? I can understand the difference between we put something on tier 1 and they have it on 2, but we have something that's on 1 that they have on 2. Like, I understand a 1-step difference, but why would there be things that are tier 1 for one company, but all the way on tier 4 for your company? That's a big.
Yeah, most of the time, so the jumps from 1 to 4, usually that's because of the financial costs involved. The arrangements between different carriers and the pharmaceutical companies and vice versa. So those are typically kind of the main reason why you see the larger jumps. I think the biggest difference between the Anthem formulary and Blue Shield formulary here is that last column where we cover a lot of those medications on medical benefit, and most of those medications, not most, majority of those medications were kind of injectable medications that were previously covered at the pharmacy, but we provide coverage at the physician's office. So it's just different levels of kind of coverage and where we believe it's most safest and cost effective kind of site of administration.
I do have a question regarding the auto assign, because in the call summary, looks like there was a big jump in calls for January and February. So when it comes to I know what 40% of them were provider calls. Did a lot of that have to do with people wanting to change their auto assignment, or is there a way to drill down into that?
Yeah, I mean, I think that, well, I'm trying, I don't know where that slide is. I mean, people are calling in. So basically our, oh, oh yeah, sorry. It's the one, it's that one.
Yeah.
It's that one. Oh yeah, so for the auto assignment, so.
Yeah, it's the next one, I think. It's the one with the pie chart, yeah.
Oh, the pie chart. Okay.
Because you see January and February is 2,100 and
Oh,
1,000
yes.
versus.
Yeah, and that was the calls into us. I mean, that is pretty expected with your population with a new plan and a new carrier. And so, I mean, auto assignments, we had prepped our call center. We had several calls with them ahead of this, and they're very used to, especially January 1, because that's when most of our clients were new. They're very, I mean, it's kind of a turnkey. People get their ID card. It says, if you want to change your primary care physician, call in. And then they were basically, if someone calls in and says, oh, I got assigned a primary care physician that isn't who I indicated or isn't who I wanted, they can go ahead and change it right there and then reissue the ID card. So again, they were, we had several calls with them. They were prepared. They had a call log. And so I think, a lot of the calls were regarding providers. So that could be just a question about the provider, finding a provider or changing a provider.
There was also, because when the previous slide where you see the numbers like 1,700 and 1,200 that were auto assigned. I actually got that wrong, 1,200 and 741.
Yeah.
So we were working, at that point, we were working off a file. And so sometimes when there is a provider ID that didn't match ours, there was a lot of back and forth that we were doing, massaging that file, trying to make sure that we got the members to the exact provider at that office. So a lot of those uptick in calls could have been, we got Dr. Jones, but we got him at this office when the member wanted him at this office. So a lot of that was also changing, or if in the file, they wanted a spouse with a different position and they just went ahead and put one position for the entire family. So there was a lot of that fluctuation too.
Any more questions?
Janita? Sorry, not a question, but I just wanted to add some additional context to a question that you brought up earlier regarding the HDHP. So going into this plan year, we knew that, you know, for the HDHP as a new plan, there was going to be a need to provide employees with a lot of information about the potential upsides to the plan as well as the potential downsides. So, you know, we did attempt to communicate this to employees in a variety of ways, from the communication guidebooks, seminars, the the benefits fair, and we spoke to a lot of employees, you know, to, you know, as best as we could respond to their questions about that, about the HDHP. So we do have, you know, we do know of some employees who, you know, who after learning about the potential downsides, they did opt not to enroll. But ultimately, f- in the right situation and in circumstances for employees, there is a lot of potential upsides, you know, for the HDHP. So, but it's not foolproof. You know, you are taking a bit of a risk in that, you know, you're hoping that you're not going to be, need to use a lot of that service for this upcoming year.
All right, thanks for that. All right, I don't have any other questions. All right.
Thank you.
Thank you.
so
All
much.
right. Okay, the next, we have a benefit provider presentation from United Healthcare. Come on down. Good morning.
Good morning.
Oh,
Great. Is ready for us?
we are.
All right. So good morning. My name is May Young. I am the strategic account executive. I oversee the city's overall book of business. Hand it over to my peer here to introduce herself.
Good morning. My name is Jacqueline Burciaga, and I'm the Field Account Manager for City of Los Angeles.
Good morning.
And we'll go right into the next slide. Effective January 1st, 2026, United Healthcare became the UHC HMO carrier for the city of Los Angeles, replacing Anthem and introducing two plans, the Signature Value HMO Full Network and the Signature Value Harmony HMO Narrow Network. These plans now serve about 3,266 enrolled employees, representing about 12.5% of the total population. This presentation here provides an overview of the transition from Anthem to United Healthcare, including member enrollment outcomes, primary care provider alignments, and early insight into medical utilization and pharmacy disruption that's been observed since implementation. And then if we could go to slide 4. So as of March, when we ran the report, we had, the report had about 8,030 members. I think we're up to 8,100 members now that were included in the HMO transition. Approximately over 1/3 of these members were successfully enrolled. with no issues, demonstrating strong alignment with initial PCP assignments. The remaining of these members were flagged for follow-up primarily due to missing or invalid PCP information. It was related to the data transmission from TALUS. With provider availability or closed panels, the majority of the members that have been identified and successfully enrolled with the provider of their choice. We have no continuity of care cases that were identified. This allows for us to focus on the remaining members and completing PCP assignments and ensuring that members are connected to an appropriate primary care physician. Anybody have any questions so far?
I guess just the question is when it came to the auto enrollments, you said that it was because of the data. What there was because it seemed
Yeah.
like there was more problems. Yeah.
The main reason for that was the PCP assignment issues where the initial file we got from TELUS did not have all the provider information. So Jackie and someone else from our team who's dedicated to the city, they were manually going through this list where there were missing provider names. Some of the missing providers had missing medical groups. Some of these providers were showing up, under other medical groups. So we couldn't just by looking at the file determine whether this member is assigned to this provider and which medical group. So that was a lot of manual work on our end. We were able to match up to the best of the ability the folks who should be in that certain provider and medical group. And if the PCP was listed in one medical group, then we would list them there. For those that we couldn't with multiple medical groups, we sent them back on the file to TELUS to confirm. So we did do a couple rounds of this to make sure that members were assigned to their correct PCP.
Okay.
And then the next one, you'll see the member service call volumes. This one is for the full HMO, the Signature Value HMO network. The call volumes were relatively low in December during the pre-implementation period, and then it increased significantly in January following the January 1st transition effective date. The majority of the calls in January were driven by eligibility questions. Reflecting member inquiries related to enrollment confirmation, plan changes, system updates, post-transition. And then by early February, overall, the call volume had declined with reductions seen across most categories, indicating that there was improved member understanding, successful issue resolution, and stabilization of the eligibility and any provider assignments as the plan moved forward into the implementation period. So for the eligibility, I know the eligibility was pretty high. These are members that were checking in on their eligibility to see whether they were in the system and if their plans were pretty much comparable to what they currently had.
Just like to make a note on the PCP assignments for both UHC and Blue Shield. One of the things that we required as part of the RFP was a retroactive enrollment period. So we asked both carriers to allow members to retroactively change their PCP to January 1st, even if they got into January and February. So that way they didn't have any disruption. They remember that panel, but it was showing as closed on their end, but they're a current patient. They could have the ability to get with the doctor that they had been seeing prior. So we did have kind of a safety net there, which probably folks got their cards in December, the holidays. They probably started calling in January, and they did have the ability to make sure that they had the provider they wanted 1/1. So that was one thing I just wanted to kind of overlay for both is through the RFP, we wanted to make sure that they had that ability.
Can I interject? As somebody who got mapped over to UHC, my card was incorrect. I immediately called. There wasn't enough information to help me when I first called. I waited, called back, and was told that it would be effective February 1st. And I was like, no, I was told it would be retroactive until January 1st, and the person I was talking to didn't have that information. So it took a couple of calls, and only because I knew, because I'm here. And so I don't know what the experience was for people who aren't here and didn't know whether or not they actually got the retroactive.
Okay, yeah, some of those things that we do see, we started to put stuff into the floor so that the customer service team knew how to handle things. There were some hiccups here and there. As soon as we found out of the hiccups, we would send them an email blast to their floor and give them some soft training. So they should be able to pull up those notes and say, oh, these guys have a retroactive period to whatever date. And I know Jackie and our service consultant had handled a lot of the calls too. And
Yes, we stepped in and when whether they reached out to us via the dedicated email that's available, or we did have several reach out and set up a one-on-one with an advocate. So whether they met with Sarah or myself or both of us, we made sure that we pulled the calls and did soft training like May mentioned, and made sure that they got their retro back to what we agreed upon for 1/1. Yeah.
the next page is the Harmony plan. So the member service calls here too were relatively low in December with a total of 70 calls. It reflected limited activity prior to the January 1st implementation. Following go live, the call volume increased significantly in January to 703 calls, driven primarily again by eligibility and provider related increase as members confirmed enrollment, network access, and primary care provider assignments. And by February 1st through the 15th, the total call volumes declined to about 175 with reductions across most categories, which indicates to us that there were improved member understanding, successful resolution of initial transition issues, and stabilization of enrollment and PCP assignments within the Harmony HMO plan. And then the next one, United Healthcare provides multiple support resources to assist members throughout the year. So we do have a dedicated microsite for them. We have a member services support team, a city-specific mailbox, and personalization one-on-one advocate appointments. These resources are designed to ensure members receive timely assistance, accurate information, and ongoing support for benefits, questions, and transition needs. This is handled mainly by our team. So Jackie and our service consultant, Sarah, handles this. To date, we have supported around 7,895 website visits. We responded to 447 emails and completed 151 one-on-one advocate appointments. And then the next slide, you'll see our team, basically, the support is delivered throughout our dedicated UHC team that provides strategic oversight, day-to-day service coordination, and direct member assistance. For me, the strategic account executive, I oversee the overall relationship and performance. Jackie oversees, she supports on-site operational needs and reporting. And then Sarah, who's our service consultant, she manages service issues and escalations. So together on team, we collaborate closely with the city to ensure timely issues of resolutions, consistent communication, and ongoing support for both the city and its members. Let's go to slide 10. So slide 10 here, this is January's 2026 medical utilization. It reflects a limited reporting period with spending concentrated amongst a small number of diagnoses. So the highest utilization here is being driven by benign and chronic conditions, including benign neoplasms, urological conditions, and gynecological diagnosis, while the remaining utilization was spread across a broad range of medical conditions. Overall, these results represents really early stage experience and will continue to evolve as more data becomes available. So the medical utilization data here is limited because the reporting period includes only January 2026 for the first month following the implementation. Again, when they become available, you guys will get more information on this. And then next slide. This is the formulary analysis that compares drug coverage between Anthem and United Healthcare to identify potential member disruption, including changes in tier placement, co-pays, and exclusions. The data used for this analysis is based on Anthem's full year pharmacy experience across all of their members, which may include individuals who were not with United Healthcare. So as a result of this analysis provides directional insights, but it's not 100% complete. And findings for this will be further refined as United Healthcare specific pharmacy claims data becomes available. And the next slide, this slide here is just a sample member communication explaining the temporary 90-day prior authorization lift that we were able to give to members during the pharmacy transition. This letter outlines how the lift helps to ensure access to medication while members and providers adjust to United Healthcare's formulary and prior authorization requirements. And the next one is a sample communication, almost similar to the other one, but it's medications that are excluded from the formulary, but were temporarily refilled to allow time for members to consult with the providers. It does explain coverage limitations and it outlines next steps to include alternative medication options and ability for the providers to request an exception to support continued treatment. And then slide 15, United Healthcare issued targeted communications to members impacted by the pharmacy prior authorization changes to support continuity of care during the transition. These notices were sent for both Harmony and Signature Value HMO plans to inform members of the temporary 90-day lift. So if a member was going to go out and get a refill, when that member got the refill, it would automatically generate a letter to let them know that they need to work with their doctor. So that's the first thing. We didn't want them to just have a 90-day lift and not have anything telling them that you need to work with your doctor after these 90 days to get your refill, to get a prior auth on your refill. So we put this plan into place so that temporary 90-day lift and exclusion status were applicable and available next steps were available to them. And some members may have received multiple communications based on their medication profiles to ensure the clarity and awareness of coverage options. As to date, we don't have a count of how many members have resolved their issues as of yet. However, the reason we did it was so that they could get notified for the lift. And I know Jackie has one person that she's dealing with. If you want to just give to
Yes,
people.
out of everyone that landed in this situation, we Sarah and I have been working very closely with the family, and ultimately, even though they got their 90-day left, their medication is a specialty non-formulary with approved alternatives. So they have been directed to work with their provider to resubmit a new PA, or they can also appeal. But we've been working with the family very closely. And I will say that they are very happy with the outcome and the service that we've provided. And that's really the only one that we have in that situation.
All right, so next page. This shows the pharmacy and formulary analysis comparing the prescription drug coverage between Anthem and United Healthcare to evaluate the alignment of copay changes and potential member impact. The majority of the medications experienced no change or lower copay, with many tier 2 and tier 3 drugs moving to a more favorable cost here under United Healthcare. For the non-formulary medications, copays may change from tier 4 or tier 3 to tier 2 or tier 1, depending on the outcome of the formulary review. It's important to note that the data used here to compare is based on Anthem's full year of pharmacy experience across all of their members. So this includes individuals who may or may not be enrolled with United Healthcare. And as a result, the analysis provides directional insight. It will continue to be refined as United Healthcare specific pharmacy claims data matures. Any questions there?
On that UHC excluded,
Mhm.
can you explain that column?
So let me see here. Some of these exclusions. So there's 13 excluded medication is here. The excluded medication, I don't know what they are. Like I said, because it's a full year's list from Anthem, but there are a few here that are excluded, and as soon as we know what they are, we could find out, and the members can either ask a provider to submit an exception or provide an alternative drug.
The other numbers above 13,
Yeah, those are UHC excluded. And I wouldn't be able to tell why they're excluded until, or because I don't know if they're coming from UHC or where. It's just a whole list of Anthem's formulary list. Yeah, so as long as we could get Healthcare specific pharmacy data, we'll be able to figure that out, see what are the exclusions, and if we could help them with getting either an alternative or better medication, because it could also be an over-the-counter medication that was excluded too. Which takes me to the next page. This slide here highlights the most frequently utilized over-the-counter medications within the pharmacy benefit. Over-the-counter utilization is primarily driven by vitamins and diabetes-related testing and supply products with additional volume from ACA-eligible preventative items. So while most of these over-the-counter drugs are excluded under the standard plan design, certain over-the-counter medications are eligible for a $0 cost when they meet the Affordable Care Act preventive benefit requirements. So eligibility here is based on age, clinical conditions, and intended preventative use. And in some cases, it requires a prescription, even though the medication is available over the counter. Examples include aspirins for cardiovascular prevention, folic acid for pregnancy support, nicotine replacement therapy for smoking cessation, contraceptives, and select bowel preparation agents. When criteria are met, these medications are covered at no cost to the member to support preventative care and improve health outcomes. So, Marlene, some of these could be on that excluded list. And the next page pretty much gives you a list of the $0 cost coverage for select essential medications to help reduce the financial barriers and support member health. This also includes access to certain preventive and safety-related medications such as Narcan. That's available at no cost through the Vital Medication Program. It reinforces United Healthcare's commitment to affordability, prevention, and opioid overdose risk reduction. And then the rest is the appendix, kind of gives you an overview of some of the things that were talked about for the GLP-1 drugs, and then also shows you some of the call list and you know what was coming in at that time. I'm just gonna pause here and see if anybody has any questions. Nope. Okay.
Thank you.
You're welcome.
Thank you. Okay. We can move on to our final informational item, committee report 2611, projects and activities, informal reports.
Thank you. This report covers the March timeframe. So, first up on page 1, we have one information item regarding a Kaiser strike. In mid-March, a one-day strike occurred that involved 2 different unions. The impact to members was minimal. Moving down the page, we have a project update on the dev audit services that Karina and Gabby from our office will be going over for you.
Good morning. So just giving some quick updates. So staff in Secova continue to review and finalize all outbound communications that will be sent to members throughout the duration of the audit. We plan to send out 2 initial announcement notices to ensure that employees in both phase 1 and phase 2 of the audit will receive advance notification to prepare for the audit launch. A copy of those can be found in attachment A and attachment B. The initial notice will go to all employees with at least 1 dependent on coverage and is expected to be mailed in April. Secova piloted a test tenant for the dev audit microsite, which includes both an HR dashboard and individual employee accounts for LAWL members. We are currently testing that website functionality and ensuring that the resources and instructions on how to upload the documents are user-friendly. Employees will use this platform to review and submit their dependent eligibility documentation. In addition, staff will be able to monitor the status of submissions and track which members are still missing their documents. Secova is currently working with their IT team to ensure that the SSO implementation will run smoothly with the city's Google platform, and staff will then collaborate with ITA in creating a city test tenant to ensure that the SSO will work as intended.
Good morning.
Good morning.
Staff also requested a detailed report from TELUS to determine the number of documents currently on file and under review. So we are currently in the process of receiving the first batch of 1,000 approved documents from TELUS. And once received, staff will receive and remove eligibility documents not pertaining to the dev audit. This will officially launch the beginning of phase 1. As noted in Committee Report 26-6, the 2-phased approach will be sequential. Due to the delay in document transfer, staff is adjusting the implementation timeline, but we do expect phase 2 to launch mid to late May. We expect terminations to be finalized around July or August, and a revised outline can be found on page 3 of the report. And as mentioned previously, staff will continue to coordinate with Secova to facilitate a timely launch of the audit. And I'll bring it back to Chung.
Okay, thank you. So over on page 4, we have a few short procurement updates for you. So for the third-party record-keeping services RFP, we anticipate having a more fully fleshed out draft available for the JLMBC's consideration next month. For the EFAP RFP, work is still continuing on this RFP. We are now anticipating an April release instead. Then on over to the self-funding item, Borden from McKean will be going over this item for you.
Good morning once again. There's a complete presentation that goes over self-funding, underwriting, and a lot of things that one, I did last year with training with some of you, and 2, I'm going to assume the report was read and that I don't need to go over word by word, but I certainly am available for questions relative to it. So I want to focus more on the highlights of what we did and what the analysis does. Can we go to the? Yeah. Okay. So we initially did a self-funded analysis, oh gosh, probably about 5 years ago. So we are now looking at that point, we did a 5-year look back. So we now have 11 years of dental data, 9 years of vision data that we reviewed and said, okay, this is what you spent, this is what you paid. And so, what if you would have been self-funded over that time? What would have been the variance? And I think that's probably one of the big keys to determining, should we be looking at self-funding? What are the actual savings? So if we can go to there's a chart. I think it's like 9. Keep going. Keep going. Little bar chart. There we go. There's the first one. This is the dental feasibility study. And in this, what we found out, so this is a deficit surplus bar chart, meaning each year when you paid your premium, how was it relative to the expenses? Were expenses higher than the premium or the expenses lower than the premium? And so the blue represents what your current program is on a fully insured basis. And so relative to that, what we determined is this, that from 2015 through 2025, over that time frame, that first of all, after we look at all the expenses compared to the premium, there was about $6.5 million that you left with with the dental carriers. Had you been self-funded over that time, it would have been a little bit different. The claims are still going to be the claims because the pricing of the claims, the providers you're going to see would have been the same. The plan design would have been the same. Nothing changes. It's just that you would have been self-funded. What that eliminates from an administrative perspective and some costs is under a fully insured arrangement, there's a risk charge involved. In other words, the dental carriers are assuming the risk, and for that they want to have that. In a self-funded environment, you're assuming the risk, so you wouldn't pay a risk charge as part of their administrative and overall cost, non-claim cost. The other area is state premium taxes are limited. You on fully insured products, you pay a state premium tax. Self-funded doesn't pay that on the claim cost, doesn't pay the state premium tax as well too. So those are some of the differentials, and because of that, our administrative costs goes down, meaning there's more dollars available to pay towards claims as opposed towards administration. So if we look over that same time, remember I said about 6.5 million, it would have been actually closer to about $12.6 million that would have been saved by the city. And that's assuming the same rates, everything you have, it's just the cost components there. In particular, it's of note, if you look at the last 2 years, 24 and 25, you see that the little blue charts, it's in a deficit position. It's below zero, meaning that your expenses for the last 2 years have been higher than the premium that you're paying. And thus, you can also see on a fully insured, if we look into the renewals, what is the carrier asking for? An increase, a minor increase, but that's one of the reasons. However, if you look at the self-funded bar charts for 24, 25, they're still in a positive direction. This is because of the difference in the admin costs. So we would have paid less for administration and so forth, and that would have not a huge surplus position, but it would have been a surplus position going forward, also leaning towards, and we'll come back with the actual numbers. We'll show you the underwriting on the dental that had the last 2 years been self-funded, you would not have been in a deficit position. You still would have been in a surplus with the same rates. So that's kind of the argument on the dental side relative to this feasibility study. And then the next slide, or go to the vision feasibility study. There we go. There, we look back all the way to 2017, and what we noticed there is, and keep in mind, the dollar cost for, or the vision rates are a lot smaller than the dental rates, and the dental and vision are both smaller than medical rates. But here, what we saw was the same thing, that over the 9-year period, you would have accumulated a margin of 1.76 million on a fully insured basis, or you realize that stayed with the carriers. And then had you been self-funded over that time, it would have been 2.14 million that you would have saved. And that's just because the cost of administration is substantially lower on the vision plan than it is on the dental plan. And but still, it would have helped you. And here's the important point to note as well, too. So the last 3 years have been a deficit position on, as you see, those blue bar charts are below the zero number. But you're in a rate cap. So when we come back and show you the numbers relative to if we self-fund in the renewal versus accepting the rate cap that's in place, it may behoove you to take advantage of the rate cap over self-funding, because if I need to increase your costs because you're paying the claims as opposed to having that rate cap in place, it would be smarter just to take advantage of that rate cap. So we'll come back with that. But that's kind of the outline here. I just want to emphasize again, there's, I believe after the feasibility study, there's still a kind of financial requirements that I outlined. I would, and I believe that the last JLMBC, we had a little bit of a discussion relative to this as to reserving requirements and so forth. A lot of it is based on how the city sets itself up with your dental and vision carriers. But typically there's a deposit required at the beginning. And that deposit is so that there's money on hand so that the carrier can pull that money from that account to pay claims. And then based on some agreed upon frequency, it can be, I've seen it as low as twice weekly. You could even have it daily if you wanted to, but that's too much of an administrative burden. Twice weekly, all the way to monthly, is going to depend on how much big of a deposit is, because you have to have enough money in there to pay the claims. And the more frequently you pay, you refurbish that account, the easier, the smaller the amount is, because obviously a month's worth of claims is a lot more than a couple of days worth of claims. So that's one of the things there. And that's one of the other thing too is when if you first were to self-fund, you might look at and say, wow, we were geniuses to self-fund because there's hardly any claims being paid in the first couple of months. Well, that's because your membership is going and incurring claims, but there's a time delay to when they're presented for payment. And so during that time, we still want to take those funds that you've budgeted, and that is going to develop what we call the IBNR reserve, the incurred but not reported reserve, so that should you ever decide not to self-fund at some point in time, that at that point in time, we're going to have to pay the run-out claims on the plan for up to that point. And so with that, we need to have a reserve on hand, and that's what IBNR reserve is for as well, too.
So you're saying we would have, if we had been self-funding the past 10 years, we would have accumulated a reserve of savings. We would have been in a.
Yeah, if you would have been self-funded, you would have had about, on the dental, about 12.6, on the vision, a million and a little bit.
But are there any rules about how much reserves you can build up before they have to be like reinvested back into?
So
Rules?
So typically the guidelines, and I have different groups that are self-funded for various different products, including medical. Outside of the IBNR reserve, for instance, oftentimes it's a good rule of thumb to have what's called a stabilization reserve. When you have, and that might be 1 to 3 months of projected claim cost on hand in a reserve. Anything above that is generated is considered excess reserve. Typically, there's reporting on both. And once a stabilization reserve has been established, the nice thing is when you do your underwriting for the future years, you don't have to have margin built into the rates. So your rates come down a little bit because you've got a stabilization reserve. And then, if you look at the last 10, 11 years, each year, it's not that your claim cost was so much lower and there was this surplus. It's just the contract that you had has a margin buildup. The carrier's going to have a little bit of margin to make sure that they have enough money on hand to cover claims. Well, your dental was extremely predictable such that that margin reserve stayed with them for the most part. And here what I'm saying is once you put that into a reserve and you're kind of the insurance carrier, you don't necessarily need it forward, because if you do have a bad year, you'll tap into the stabilization reserve, and in the next year, we underwrite a little bit of margin to build that up again. So it's just, self-funding is just another financial arrangement that I think would benefit for the JLMBC to consider. Definitely dental in the upcoming year, and we'll see on the vision because of the rate cap. Any other questions?
Would this require more staff at benefits?
I think it would require some coordination, but not necessarily more staff at this point. Thank you.
Thank you, Board. Okay, going back to the report. Next up, we have an update on the ACA. So following the disbursement of the ACA 1095 forms in February last month, Benefitscape had submitted the city's ACA data file to both the state of California and the IRS, and that fulfills our requirement for the 2025 tax year. Staff will now start on the 2026 tax year. Moving on over to a staffing summary, we have one update for you. I'm happy to announce that Lanelli Abastal accepted the emergency appointment for the accounting records supervisor position. She is previously an accounting clerk within the Employee Benefits Division's accounting section, and will be taking on that role going forward. And that brings us to the end of this report. I'm happy to answer any questions and also to take any items you may have for future agenda.
No question.
Okay, thank you. The meeting is now over.
That's my question. Is like this one doesn't seem like it's working.
Oh, is the one that I have it set